All right, welcome back to Daybreak. It's now 14 minutes to 8 o'clock. You're still watching the show that brings what you need to think about as we begin the day. My name is Sam Gituku, and I'm joined by the Cabinet Secretary in charge of Health Affairs, that is Sicily Kariuki.
Thank you.
Thank you so much for making time for us. And I want us to begin with what Kenyans have been saying on Twitter, on social media rather, as soon as we told them that you're coming to studio to talk about the situation with cancer as well as universal health care and the situations that we have in the counties. I want us to take a look at what they've been saying on Twitter. This is Leon Leidigu says that a real crisis. It is a real crisis. The number of Kenyans, let alone the many waheshimiwa, has admitted that Apollo Cancer Center in New Delhi alone will shock you. I met a Kenyan girl who narrated to me how after 2 years ago, she put her life on pause to bring her mom over. There is someone talking about the situation that Kenyans have to go seek medical attention in India. There's still the same person. There's an estate. I visited Juzi at Jasola Vihar with about 6 or 10 story buildings where Kenyans are charged 50,000 or 75,000 Kenya shillings rent for a 2-bedroom house as patients need a place to stay as they seek medical treatment. Kenyans are suffering out there. That is a journalist who is based in India. Then someone else is Diego Lawrence, is that we need a working health system. Honorable Sicily Kariuki, or CS Sicily Kariuki, please also address the issue of exorbitant parking charges by private hospitals. Kindly outline realizable plans to ensuring better healthcare. UHC is just on TV. Those are just some of the views that people have. Then, right, so let's begin with the situation with dealing with the cancer situation. And of course, there have been several plans that the government has been putting in place. From where you see it, how far are we with the realization of addressing the cases of wrong diagnosis, early diagnosis, and ensuring that we're able to treat cancer in the country?
Well, thank you very much for having me here. And it is true, I mean, we are not sitting in a very good place in terms of cancer. The numbers continue to rise of the cases that are detected. Currently, we are talking about 48,000 or thereabout, 48,000 Kenyans per year affected by cancer. And of these, we've also recorded about 33,000 Kenyans dying on matters related to cancer. Now, where is the problem? The problem is that as the numbers continue to grow, we are recording majority, 65–75% of the cases are actually detected in hospitals when they are too advanced, stages 3 and 4.
Right.
What does that mean for us? It means then giving, treatment that really works becomes a real challenge, stretches the health system, as it were. And that is why in our current strategy, we are looking at sensitization at the grassroots level being one of the most effective interventions moving forward, so that sensitization leads you to early screening. Early screening, in case you're exposed, leads you to early detection. Early detection leads you to treatment, which would have better outcomes than the case that is obtaining right now. On the other hand, we are also looking at investment in terms of infrastructure, additional infrastructural support. We have, in the last 2 years, put up 9 chemotherapy centers, across the country. Right now, we are putting up radiotherapy centers, 4 of them. We are calling them the Centers of Excellence, and are in the process of being constructed, as it were. We have secured the budgets to also be able to equip this within this year. We also note that the KU Teaching and Referral Hospital will be opening up its doors as a referral hospital that is high-end at level 6 in the coming few months. Again, it has or comes along with the specialized care for cancer patients. Of course, Moi Referral and Kenyatta Referral continue to give care, as it were, but as you can imagine from the numbers I've shared with you, the capacities are completely stretched.
Sure.
We have seen also in the private sector, especially the Aga Khan, invest in a cancer treatment, including investing in the PET scan. That is one of the reasons that most patients actually go to India. And so the investments are happening, they're happening, but the numbers continue to grow. So my message for you... Faster
than our investment of services.
Faster than our investment, because this is infrastructural, but also technical investment.
Right.
And as you will, investing in infrastructure is also not matched by our capacity to output human resource capacity, which is another side. But we are addressing that as well, because we have a poor ratio. We have a poor doctor or health worker ratio to the patients. But we are working, it's not, switch on, switch off. It's a problem that has grown over time, but we are doing the best we can to address this. But for you, the ordinary Kenyan, I think have a responsibility and role. Go for early screening. If it's detected early, then you have better chances of actually being treated. Okay, we'll get back to that. But first, from your knowledge, how much time does it take for cancer to move from stage 1 to 2 to 3 to 4? It really depends on the type of cancer you're looking at. There is that which lends itself to multiplication and movement quite rapid. Leukemia falls in that category. But there is that perhaps will lend itself over many months, many years for it to be able to progress. Then again, it depends with the personality. Because if you're predisposed to other health conditions, it then follows your system is, your immune system is not as hardy. Therefore, again, that it will depend. You may not put it in a classification in terms of 1 month, 2 months, 12 months. It really depends. Interesting that you say that it's the responsibility of the Kenyan to go for screening to enable early detection. But still, you see a situation where there has been several cases of wrong diagnosis. Talking about the late Bob Collymore, the CEO of Safaricom. I mean, he is a man of ways and means, and he had access to the best of treatment, but still went through wrong diagnosis. What's wrong with our human capacity or human resource capacity to be in a position to detect early and subject a patient to the correct treatment? I am not sure that there is anything very wrong with our human capacity to be able to detect. And this, again, is really not a Kenyan problem. I want to look at cancer being a global phenomenon that is actually ravaging other countries in addition to Kenya. Of course, that does not remove the pain from us as a country, as a Kenya, as a health system, as it were. And so there have been cases of missed cases when it comes to diagnosis, but there have also been equal chances of people who went early and, the right diagnosis was given. So again, I don't think that this has any bearing to do with our human resource capacity, as it were. I asked that because now looking at some of the figures we have is that the specialist doctors in terms of oncologists have less than 15. We're talking about 12. I don't know what the exact figure is. And the number of nurses is similarly challenged. What are we doing to have more professionals? Because, of course, it takes time to train. Indeed. I mean, I want to confirm that in terms of the generality, in HR, we are not doing very well. The recommended global best is 23 human resource to 10,000 population. We are 13. So you can see we have a gap of 10 for every 10,000 population. When it comes to cancer, the doctors, we have 23 doctors. The population that is recommended, again, is 1 doctor per 100 patients because of the delicate nature of cancer. Currently, the ratio that we are having is 1 doctor to 1920. 1,920. 1,920. So you can see we have to do a tenfold job to be able to get the required capacities. However, we have most of these oncologists moving between facilities to be able to then give cover. And we do recognize that to be a major gap. And in terms of intervention, therefore, we've actually gotten into partnership in terms of training. And currently, we have quite a number of oncologists out of the country who are going through training. How long does it take to train a specialist in that area? Anywhere 5 years, even to 7. Wow. As it were. But for nurses, what it is we have done, we have come up with our own homemade remedies, where we have, for example, MTRH, partnering with colleagues, and peers from out of the country to train nurses. We have the Nursing Council of Kenya as well, partnering with AMREF to train nurses, as it were, right in the country. So there are interventions happening to be able to get the numbers up. The last time you were here, I believe it was on the 15th of January 2019, you told me that we were going to see
the commissioning, I don't know whether it was commissioning or groundbreaking of the Kisii Cancer Center of Excellence. I was checking yesterday, and what I understand is that is yet to happen. They are hoping that it will happen in October. I mean, what's delaying this process?
True. We have had some lengthy negotiations in terms of the funding and the contracting processes. But as I speak to you, that process in terms of now the negotiations has come to an end. It's come to a closure. We have the financiers who have given a no objection for this investment to proceed.
Right.
So we do expect that will be happening.
So for the other cancer centers, because you said there was going to be cancer centers of excellence in Nyeri as well as Mombasa, what's the progress?
In Mombasa, we already are putting up a radiotherapy center for start, and the construction is already happening. It is, we have also secured resources for radiotherapy equipment in that place as well. So that you'll be seeing motion and a closure hopefully within this financial year in Mombasa. In Nyeri, the funders again are in consultations with the National Treasury and ourselves, and we are hoping again within the financial year, the consultations, the contracting processes, and hopefully commencement will be happening, because that is funded from, partners who are loaning the government of Kenya, if you will.
Okay. Yeah. Do you know the cost?
Not of head, but the Kisii one is going to the range of about 2.5 billion shillings.
Okay.
Yeah.
All right. I look at some of the information that we have. For instance, the cancer treatment centers in Nairobi are talking about 10. Only one is public. That is the Kenyatta National Hospital.
Yes,
you can correct me if I'm wrong.
Indeed.
The others are private institutions, 9 of them. And when you go around the country, you don't see the same level of investment like you would see at K&H. So what are you telling Kenyans? Because those who are able to raise funds, they can travel to India. How about that person who cannot?
Let me come back again and say this is what I'm saying to Kenyans. Conscious of the dire need of, especially the vulnerable Kenyans, conscious that UHC will not be realized unless and until we invest. We have invested in Kenyatta Teaching and Referral Hospital. Is just about to get operational, and my timelines are anywhere September. I'm telling Kenyans that we have also invested in Moi Referral, MTRH, as it were, and in there actually we have secured one of the most modern state-of-the-art equipment that will be up and running in December. I'm also telling Kenyans the reason we are putting up we have opened up the 9 chemotherapy centers across the country, Garissa, Kisumu, Bomet, Nyeri, Embu, is because we are conscious Kenyans need to get access to this treatment. I'm also saying to Kenyans, we are opening up 4 radiotherapy centers to back up the chemotherapy centers. So I'm telling Kenyans we are consciously investing in here. To make it perhaps also go down well with the ordinary Kenyans. To date, we have 15,000 patients under NHIF cover who are going through or accessing chemotherapy treatment in the private sector you speak about, on the cover, as it were.
Are they civil servants or they are?
Across the board, it's really open.
I'm asking because a viewer, Wanjiru Mbogo, is asking that, is saying that, ask the CS if there are free screening centers in Nairobi, and which ones are they? Because Aga Khan only covers NHIF civil servant card holders. Aga Khan is a private hospital.
Yes, it is. It is private.
So would those 15,000 you're saying, are they all, can you have someone who is not in the civil service and going to Aga Khan for treatment?
Indeed, because, NHIF cover is both for civil servants and also a private sector, as it were, including also the informal sector who have taken on that cover. Yes. So, but I think, Sam, let's move away the conversation from what is in the private and obtaining in the public. Let's look at the totality, because the reason we have invested, the private sector has invested in the sector, is because there's a population that has no problem being served through the private sector. And we are a country that encourages investment in the private sector, as we do the public sector investment as well. So let's not sort of break it down and say what is happening where. Let's look at the entire health delivery system. And talking about investing in the treatment of cancer, of course, there are billions of shillings that will be taken to India for people to access treatment there. I mean, Waziri, in your thoughts, what do you think is the best way forward so that
that money going to India remains in Kenya and people are accessing that. What sort of collaborations are we having with other countries?
Perhaps if you had me talk before, it is not desirable position for us to be exporting patients, because it denies us also of developing our own health system, as it helps, and it also denies the families, you know, money that would otherwise be spent in the Kenyan economy. So we are re-looking at guidelines that help us allow people go to India, so that really, once we have the right capacity, in this case for cancer treatment, we then will not necessarily want Kenyans to keep going to India, as it were. But for the time being, you're caught in between a rock and a hard place. Our capacities and the numbers I've shared with you, the numbers are increasing. We are working on building the capacities now. We are working on investing in the infrastructure now. It will be careless of my office or the government at this point in time to disallow. But the mid-term, long-term strategy for us is to make sure that we have a resilient health delivery system that then, even for you from where you sit, you will make a decision and you have no reason to actually get out to India or any other country for that matter.
Of course, it will take time to invest. But now I want us to transition to another story that is talking about the universal health care. You started the piloting stage in December 2018 in the counties of Kisumu, Isiolo, Nyeri and Machakos. Let's cross over to Martin Munene, who is in Nyeri, just to give us an update on what's happening on the ground. Of course, you've been piloting this process for more than 6 months now. What can you tell us in as far as patients or the citizens of Nyeri County accessing health services under the Universal Health Care Coverage Program?
All right, very good morning to you, Sam Getuko. And I am actually standing outside the facility that the CS actually launched the registration process for this particular county into that, or into UHC, that is the Nyeri Town Health Center. I can say, Sam, confidently that we have seen the numbers of patients accessing medical care actually go up by over 50%. And therefore, this means that a lot of people who are not able to go to hospitals earlier can now be able to actually go. But then that in itself presents challenges when it comes to it strains the infrastructural development when in hospitals. It also challenges the HR capacity in the facilities within Nyeri County. For example, Sam, you're talking about cancer. For example, Nyeri County has about 25 medical officers. It has about 30 specialists. And when it comes to cancer, we've got one specialist who serves Nyeri County, but also the region. Now, Nyeri County, for example, is leading when it comes to lifestyle diseases, and therefore it means that there's a likelihood that there are going to be more cancer patients here than probably some other places in the country. And I understand that it has even forced this particular specialist to be here twice a week, and she's supposed to actually move from not just within Nyeri but also into other facilities. So Sam, what I can say is that the issue of whether this particular program or project is working, we can say that it is working. Now, the question that a lot of people are raising, the residents here in Nyeri, but also when you speak to medical practitioners within the county, the question they're raising is the issue of how sustainable this particular project is, because like I said, the numbers of people who are seeking medical attention has gone up. So the question of whether this is going to be sustainable, even when it goes across the country, of course arises. But as we speak, Sam, a lot of people who are not able to access facilities earlier are actually able to do that. But the numbers of the people who are serving them has continued to be a challenge. I understand, for example, Nyeri County has about 23 doctors who are undergoing training to ensure that they become specialists. But still, like the Waziri has said, the numbers, when you look at the numbers of the medical practitioners and the number of residents, Nyeri has a population of about 900,000. You'll see that those things do not match.
All right, and Martin, as you talk about the universal health coverage implementation, what do you have to say in as far as the referral system in that county? Is it working efficiently, where if you have as a minor condition or ailment, you go to the primary health centers?
All right, Sam, that has actually been one of the major challenges also that this particular process is facing, because a lot of people still prefer to come to, for example, the Nyeri Referral Hospital as opposed to going to the dispensaries. And when we speak to the county government or the medical practitioners within the county why this is the case, a lot of them say that the people or the public is not really well informed, because people still have the feeling, or people still have the mentality that for you to be treated well, you have to go to the highest level or the highest hospital in the county. But we understand that the dispensaries have doctors, the dispensaries have medicine, but people still opt to go to the higher hospitals. But now, initially, the county government was considering sending people back to the primary healthcare centers. But then, again, health is a human right, and therefore that was also faced with challenges, and therefore they decided to be treating. And now maybe what they're trying to do is just mobilize people and actually create awareness to people rather, and help them understand that you don't have to travel, for example, all the way to Nyeri town. You can go to your facility near you, you'll get the services, and if there is need for you to be referred up to a higher hospital, then that will happen from the hospital level. But as we speak, Sam, there's still that challenge of people coming to the referral hospital instead of them visiting their primary healthcare centers. Sam.
All right, thank you so much, Martin Munena, coming to us live from Nyeri County. And Waziri, you hear our reporter there talking about the situation in the county. And you've been doing a study in the 4 counties. Does that reflect what you've been gathering? And then how do you move to the next phase? Because you told me that it's going to take between 6 and 1 year for the piloting stage. How do you move on to the next full rollout?
I mean, your colleague is spot on in terms of what's obtaining on the ground. What's obtaining on the ground, and is a reality, is that we have managed to cover an addition of 40% of the population through the public facilities that would otherwise not afford, and therefore would otherwise not get out to seek medical care. What that means for us is that then we are able to actually detect some conditions, i.e. what we've been talking about at an early stage, and are able then to escalate that with better health outcomes for the individuals. In terms of what lessons we have taken out, we've taken out very positive, and that is one of the most positive in terms of the quantum and people who are out getting out. Number 2, we have also taken out a population that now knows health being the right, that they will be asking for more. What that means, the flip side, is that then we must really deliver that more that they are asking for. What we have also gotten out is a confirmation to us as a country, as a government, that UHC really can work. Not because we didn't have a political commitment as we got started. We got started because we had that commitment. But we were piloting so that then we actually stress and apply, you know, the right conditions for us then to be able to say, so how then does scale up at country level look like? And what resources do we really require? And what changes do we require in the systems? And it has also come with a very positive lesson that if the national government and the county governments agree to actually collaborate in some of these interventions, they can be done within a shorter time than, you know, a planning horizon of 5 years, 10 years. It can be done. This has only come to happen because we have collaborated, and we've been very deliberate between the 2 levels of government to work together. Looking at the flip side, the other side, there is always a positive to a negative, and that is how life is made. We knew very well that we were going to meet with challenges, even as we went to pilot. Even now, we know we are going to meet with challenges as we cover the whole country. The determination to overcome the challenges, I think, is what counts and what matters. And sustainability of UHC for Kenya will count for much in terms of addressing the issues of sustainability. We are currently looking at that, and we are, you know, jointly with the governors again, asking the question of sustainability, because this is not one of the programs you want to, again, start and switch off. It cannot be switched off. It belongs to Kenyans. Now, how are we going to address the issues of sustainability? One, we have to bring back confidence to the public health system. That is what has been lacking, and that is why when you ask the question about referral, it is true, because we have lost confidence in the public, you know, public health facilities, particularly at the lower level. For several reasons, you find people preferring to go to the center, to drive all the way from Kieni in Nyeri to come, you know, to Nyeri PGH. Why? Because the dispensary or the health center closest to your village does not have the drugs that you're looking for. sometimes does not even have the HR that would be attending to you,
right.
that there isn't even running water in some cases. And so therefore, over time, over the last couple of years, we have lost confidence as Kenyans in that. To make it worse is that although we are investing through NHIF and there is contribution that is mandatory from ourselves, 75% of the capitation through NHIF has been directed to the private sector. What does that mean? It means the public sector facilities are then staffed of any resources as it were. And then it's a cyclic, it's a cyclic issue here.
Right.
That's the one we are trying to nab and address.
I look at the budget for this year from the figures of the National Treasury. It shows that 47.8 billion shillings was set aside for providing universal health coverage to guarantee quality and affordable health care to all Kenyans. I mean, how are you going to utilize these resources in the next 1 year?
In a couple of interventions, I was going to address the issue of HR. Again, the ratio that I've given you speak to you very directly. We have to be very, very strategic in how we utilize some of these resources to back up what the counties are doing and investing in human resource. To date, about 60% of the money that is with the counties dedicated for health is going to P&E, is going to human resource. Left with, anywhere 35% to then do development, to avail commodities, and to expand where they choose to expand. So in that space, we have discussed and will be jointly implementing a community volunteer strategy.
Yes.
What does that mean? It means that we are going to be engaging, sensitizing, and training community volunteers who will do part of the public work at the community level, including sensitization for immunization, sensitization for nutrition and lifestyle issues, sensitization for ANC, the antenatal clinic visits, so that then by remaining within the community ecosystem and doing this sensitization as it were, they will have removed a proportion of the burden that would find its way to the health facility. So we'll be investing in that space. Okay,
I want to respond whether that money is part of the full rollout or when that will happen for UHC. But as you do that, we have seen situations in various counties, a case in point of Kirinyaga County, where there has been a standoff between the county government and the health workers to the extent that the Kerugoya County Referral Hospital at some point was quite devastating, the conditions there. I mean, what are you doing as a ministry to help these county governments that are still learning 7 years down the line to manage HR properly and ensure that the health facilities are good to go for the citizens to seek medical attention there?
I mean, we'll find some of these isolated cases as we move along. The best thing is to be able to come around the table and have an understanding at the county level. Whenever we've been called in, we've gone in. In the case of Kirinyaga, the medical board, which was responsible to lead an inspection, from the headquarters, as it were, did go down and identified all the interventions that were required for us to give an environment that was conducive for the workers to be able to be more productive, as it were. So we're moving, but we are limited in how much we want to do in a respective county. But then if we partner and agree on a framework of resolution, we always do. We always shall.
What is your role in such a situation? It's gone on for so long. How much can you do?
You can't do much when a matter is in court. I mean, however much you want, you can't do much when a matter has already gone to court. We were involved before the matter went to court. Now, the matter is out of court because the court has ruled. And I guess then we'll be looking at the possibility of enhancing the capacities in there.
So when the county governor, Anno Iguru, says that medical officers who didn't report to work because of the standoff and after the court order saying that their strike was illegal, when she says that they are going to fire some of those, obviously it's not the best of situations because after that you have to disrupt the service provision. Do you have any solutions?
We don't have any solutions. And the reason we don't have any solution, this is a relationship between an employer and employee, as it were. And sort of if every time there's a matter like this, the national government will move in to give additional capacity, if we will, In this case, we have had discussions with the neighboring counties where certainly the patients are being diverted to, or have been diverted to seek attention, as it were. Yes.
All right, and I want us to focus on something that has been troubling or threatening Kenyans the past few weeks. I think it was in the month of June, the Ebola scare that we heard of cases in the neighboring country, Uganda. And then we saw your ministry going to assure Kenyans that we are safe from the virus. We saw you at the Jomo Kenyatta International Airport. But my focus is more on our porous borders with the neighboring countries, talking about Busia, Malaba, Taveta with Tanzania. How much of investment have we put in terms of screening? Because yes, we see some level of screening at the JKI. How much of that is happening at the borders with the neighboring countries?
Well, I'll come back to that, Sami, to confirm that we are prepared and, we are in control. But allow me to remain with the UHC issue a little bit. You asked what the budget was going to be doing, the budget that has been appropriated. I think it's good to, again, note, in addition to the HR gaps that we'll be working to support, we'll also be working to support, if you will, availability of commodities, pharmaceuticals and non-pharmaceuticals. Now, one of the success cases that has been registered, even from Nyeri, as you listened to, was that if you go into any public facility today, you are able to get your usual drugs, in addition to the tests that are required, the diagnostic. So part of the investment will go to that. We are in a conversation, because we have not closed this, we are in the planning stages with the governors, and we will be building consensus in terms of how these resources get to be used, in addition to their own resources, as it were. We do think if we do joint planning, the outcomes are going to be better across the country. And therefore, we'll be back again to speak to us in terms of the approach that we'll be taking for the scale-up. But we are determined that we'll be doing the scale-up. We, in a place of planning, I should be able to come back and confirm, but certainly it will be happening within this calendar year. Okay. The scale-up will commence this calendar year. 2019. Yes. Let me come back to the Ebola issue and just respond to your concern. That screening, the enhanced screening is not just happening at Jomo Kenyatta. It is not just happening, in the places which are very open and obvious. It is happening in all the border posts, as it were. We have positioned qualified human resource who have been trained in matters of screening, investigation, and also screening. We have also ensured we have the protective equipment in all the border points. We also do have isolation facilities in the major border points, and that's one of the things that are so obvious if you move to. And therefore this speaks to the response contingency plan which you have put together, which now we are effectively implementing. We are also, with our colleagues responsible for immigration matters, we have also been in touch with them, and they are giving us cover around the porous borders you spoke about, and they are keeping vigil and a bit more alert, because then we know what it is we need to be looking out for.
Well, as a country, we may do as much as we can to ensure that the virus doesn't get into the country, but just in case it does, how much of training have we done for health workers to be in a position to detect and subject a patient to the correct treatment?
Sufficient, actually. We have sensitized the health workers across the health facilities. We have availed self-reading materials. And these being the health workers, they already have the basics. We have sensitized, one more time, those ones who are coming into contact or would be more exposed at the border post or the border posts.
Right. And Waziri, as you end up, allow me to ask this question, because on the 26th of January, we saw you at the Directorate of Criminal Investigations, of course, over that controversial matter, the allegation that there is a plot to assassinate the Deputy President. I mean, what has been going on? Have you been able to record a statement, and how far is this?
Sam, I had hoped actually that's not one of the questions, because it has nothing to do with health that I was going to respond to today. But being that I am a leader, perhaps I have to behave in a civil way. That matter is currently under investigation, so I think it needs to be treated as a matter under investigation. However, Sicily Kariuki believes there is a God in heaven. Okay, there's a God in heaven sitting to plan anything, let alone that kind of allegation, is very sad. Completely very sad. I look at myself in the mirror and I say, Sicily, who are you? Is it that you don't know yourself? Is it that people know you more than you know yourself? So, I mean, I want to leave the investigators to do the work that they need to do. From where I sit, I have sufficient on my table to want to focus on, so I don't want to be disrupted. Okay. So if this was one of the schemes for disruption, I'm sorry, I have a job to do, I'm trying to do it.
All right, yes. Cabinet Secretary in charge of health, actually, we thank you so much for making time for us and sharing your views in as far as the universal health coverage implementation is concerned. And there are several matters. We hope that enough can be done to salvage the lives of many that are going through the cancer menace. Thank you for your time. Thank you for having me. All right, and up next is Engage with Willis Raburu. He'll be here with his guest to talk about several matters that are affecting you socially, so stay tuned for that.